Good afternoon, everyone. If you're on the East Coast or Central Time, it is afternoon your time. If you're joining us from the West Coast, it's still morning. But thank you for taking an hour out of your day today. We are excited to host this webinar. This is Medix Care Management that is bringing this to you today. We are a national company, Medix. We're based in Chicago. And I am your host, James Jacoby. I'm the Senior Account Executive with Medix, and I cover and service our New York and New Jersey markets on the East Coast here. And we are here today to talk with you about chronic care management. It is a growing topic in the healthcare industry. You may have heard of it before. It may be new to you. So either way, this is going to be a very informative topic today that will be presented by Laura Wilkerson, who we'll introduce in just a second. But whether you're a patient, you're a nurse practitioner, a physician, really anyone that works or serves with the geriatric population and Medicare, even in folks in your family, this is information you can use today and share that can better the care for those folks. So without further ado, we're going to get into this. First, just a little bit about me. My background, I've been in the healthcare industry for over 10 years. My focus is really around hiring and recruiting with various small and large organizations. We provide numerous different workforce solutions to help companies grow and to help talent find the perfect, career path for them. I do a lot of work in government. I spend a lot of time and have a lot of background in Medicaid and Medicare with niche programs in that area. I am on the board of directors for Case Management Society of America, both now in Boston in previous years and now in New York City. And I have spoken at some industry conferences if you've seen me around on the East Coast. With Laura, I'll introduce our presenter today. Laura, she is a graduate of Michigan University. She has worked 3 years before dedicating her career to geriatric care. She, back in 2014, founded Advanced Medical House Calls. And she's going to talk to you more about that today and what that business does. But it has really taken off, especially with some of the focus around CCM that we'll get to. She is also very interested in mentoring nursing students, facilitating and assisting with APRNs. And over the past year, she's instituted a formal CCM program into her practice that is really in the pioneer stages around the country right now, and she'll get into that as well. So without further ado, I'd like to hand it over to Laura, and she will begin the presentation. Hi, Laura. Oh, excuse me, one more thing. Logistically, I'd like to mention that this will be an interactive discussion. So if at any point, if you're involved in the webinar and you have questions, please shoot over to the conversation pane on your left. You type in your questions there. We will have a Q&A at the end. And we'll cover a lot of questions we got before the webinar, during the webinar. And if you'd like notes from today's presentation, we will send you out a hard copy of the presentation to your email address that you use to register for today. The information presented is an approach, a view, and an opinion. And on current practice, it may be helpful to others who face similar practices. So more than anything, we want this today to be used as a discussion point in a conversation as we talk about chronic care management. So now, without further ado, here is Laura.
So I wanted to say thank you. It's a privilege to be a part of this webinar, James. I'd like to definitely talk about our chronic care management program here at Advanced Medical House Calls and kind of define out what that chronic care management program looks, like to our practice based on CMS's guidelines, how we implemented it, closing the gap between geriatric care needs and the needs out there for them, discuss the financial impacts and the quality of the impact of chronic care management to the patient as well as to the practice, and then talk a little bit about the barriers and the resources that are out there for people to implement chronic care management. So just a little bit about chronic disease and the burden of chronic disease. Chronic disease is prevalent in Medicare beneficiaries, with about 4 out of 5 having 2 or more chronic conditions, which of course this leads to increased morbidity and mortality and poor patient outcomes and an increase in functional decline. This in time increases the expenditure of Medicare dollars, and we all know that that is already a health concern, or a concern of our healthcare at this time. Here's a list of the chronic conditions that are most prevalent in the elderly. They have an increased incidence of hypertension, chronic kidney disease, ischemic heart disease, and Alzheimer's disease and dementia. Medicare recipients reported a lack of care coordination with unmet expectations in chronic disease management between care expected, care outcomes, and the care that they actually received. Not having a provider that met the needs of their complex diseases and a lack of a medical home just leads to an increased incidence of these diseases being left untreated. Disparities in care coordination with the elderly and the benefits of a chronic care management program. There's an increased number of Medicare recipients, and this number is only getting larger and larger. 1 in 5 Americans will be eligible for Medicare by 2030, with people 65 and older expected to account for almost 20% of the nation's population. People are living longer, which means that the number of elderly with chronic conditions will dramatically increase, and they're already having trouble getting it where they need it. In the United States, there's a lack of gerontologists, geriatric nurse practitioners, and geriatricians. Currently, there's 23,000, and according to the American Geriatric Society, this is a great lack. Comorbidities, of course, always affect a cause and decrease activities of daily living, thus making it harder for these patients to get out and seek care when they need it. So typically what they do is delay their care, which increases costs. Multi-generational caring and not enough paid care providers make it hard for the elderly to get to the appointments and to seek the care that they ultimately need. So what is chronic care management? Chronic care management is a solution, a care coordination, the use of care managers and care coordinators. It was a CMS strategy to improve effectiveness and strategy to deliver healthcare systems, targeted at the healthcare needs of the elderly to improve those outcomes. And chronic care management is one such program. So chronic care management ultimately encompasses time services, which relates to 20 minutes in one billing month of non-face-to-face time. It's a person-centered care plan that can include calls to the patient on education, referrals, lab interpretations, anything that you would consider non-face-to-face time, unrelated to their visit. Its chronic care management is a coordinated care between multidisciplines, skilled nursing, therapists, social workers, other physicians. And CMS has recently recognized this as a service that we actually render in our practices. They've lightened up their requirements for it. In 2015, the requirements to initiate chronic care management into your practice were so stringent that most providers didn't take advantage of billing for chronic care management. It was always something that they were doing, but they weren't necessarily billing for it because of the potential audits that would come with that. So in 2017, Medicare lightened up on those billing requirements and made them much less stringent than they previously were. So fundamentals for chronic care management. What's required for chronic care management and who is eligible. Any patient with 2 or more chronic conditions are eligible for chronic care management. What's required of the providers to bill for chronic care management. Some of the requirements for billing for chronic care management are that the non-clinical provider, it could be your nurse, it could be a medical assistant, or in other states, I don't know if you have healthcare associates, but it does not necessarily have to be the physician or the nurse practitioner provider. They need to document 25 minutes of time spent with the patient. This could be educating them. This could be collaborating with their other physicians and specialists, but it has to be 20 minutes of documented time. There also has to be a care plan that's put in place. This does need to be by the provider, and it has to be individualized to that patient specifically. So I think I already kind of hit on what time counts for the documentation requirements. That, again, that would be any education or any conversations that either you call the patient or when the patient calls into your practice that you can document, and it does have to be documented. We have gone through a personal audit, and they did want to look at those documented conversations. And then we'll go over how the providers are reimbursed and how to avoid difficulties. So Medicare patients with 2 or more chronic problems. These are some of the chronic problems that are listed out on the CMS website. This is not inclusive, but these can be some of the ones that you incorporate in your practice. Anything that puts the patient at risk for an acute exacerbation, decompensation, or functional decline that's expected to last 12 months or until the death of the patient are definitely conditions that qualify. The billing requirements for a chronic care program are as listed. So one is that you need to provide 24 access by telephone, 24 hours a day for urgent care, for urgent needs of the patient. So you just want to make that clear when you're implementing this program that this isn't something where you call in for maintenance. It's for those urgent care needs only. It's managing and coordinating transitions through care and making referrals. Provide visits as needed in a timely manner based on the conversations and goals that you set up with the patients in their care plan. Provide some preventative services, immunizations, health maintenance, medication reconciliations, and collaborating with pharmacists. One documentation requirement is that when you initiate a patient into chronic care management, that they have to be seen within 1 year. If the patient hasn't been seen in your practice within 1 year, you need to bring them back in for a comprehensive visit, an initial Medicare Welcome to Medicare exam, or a wellness visit to start that care. One of the new changes for 2017 is that you need to document consent to start services. Now, this is a little bit different than 2015 when you actually had to get written consent. Now you have to document that you've spoken to the patient about chronic care management, that it is applicable to Part B, and that there are copays, and that the patient can opt out at any time. Just like we discussed, a patient-centered plan of care that is reviewed and updated as needed. My suggestion to that would be anytime they go into the hospital or that the patient has had an acute change in status. All team members that are in your chronic care management program must have access to this plan of care. Chronic care management, a lot of practices like the idea of chronic care management, but instead of maintaining the overhead in their office, they will typically find a company out there that provides these services. If you do outsource your chronic care management program to a company, they must have access to that plan of care. And that plan of care, although they may have templates that they put together for you, it does have to be very much individualized around the patient. Once that plan of care is constructed and put together by you and your team and the patient and their family member or caregiver, you must provide that patient with a copy of the plan of care before you start to initiate chronic care management services. I personally believe it's also a benefit at this point that you not only send it to the family and the care providers, but you also send that plan of care to any referring physicians or any specialists that this patient has so that you're all on the same page. Another eligibility requirement for chronic care management is that you must use a 2015 or later certified electronic health record. The new requirements with Medicare and the MIPS and MACRA are that you transmit this via the web portals and download those to the other providers. Medicare did lighten that requirement for chronic care management only and said that you could mail or fax the plans of care. And then again, like I said, you need to document at least 20 minutes spent non-face-to-face time with that patient. So what time counts and whose time counts? So depending on who you decide leads your chronic care management program, whether it's your physician, your nurse practitioner, or ancillary staff, the time that counts is any time spent in reviewing labs, x-rays, consult notes, referrals, arranging outgoing referrals, or speaking to members of a multidisciplinary team such as skilled nursing, physical therapist, behavioral health, or speech therapy. All of this time counts as long as you document it. I can't stress the importance of documentation. If you don't document it, according to CMS, it really didn't happen. Answering patient phone calls, emails, and portal messages related to the chronic conditions that you have outlined in your plan of care, they all count. Any telephone education that's done in one calendar month counts toward this time. And again, like I said, depending on how you want to structure your program, all members of your clinical team, nurse practitioners, physician's assistants, doctors, RNs, MAs, and clinical office assistants count. But what doesn't count is any receptionist who's making an appointment, talking about medical insurance, billing questions, or anything like that. So this is a snapshot of the latest chronic care management codes and the required staff time to bill these codes. These are the codes that you can choose that will be based on the complexity of the patient needs and the amount of staff time being spent monthly. So you can see there that it's kind of an ongoing build upon service. But that initial initiating visit is that G0506 code there, and you can tag that on to your CPT codes for your wellness visits. What you cannot do is you cannot add that code to a new patient visit. What can and cannot be billed. Appropriate CPT codes for the time services billed at the end of the month are the ways that you will get reimbursed, which is the chart that we just showed previously. All of those codes are applicable. 2 ICD codes indicating which chronic illnesses that you're hitting on. There can be more than 2. I'll be honest with you, most of my patient population has 6 or more. What cannot be billed with chronic care management? You cannot bill, Medicare considers it a duplicative service for care plan oversight, like you'd maintain when you open the patient up for skilled nursing or therapies. Transitional care management, because they look at that like it involves those 30 days post-discharge. Any new patient office visit, and just keep in mind that if you have not seen a patient in 3 years, that patient then to your practice is considered a new patient. When a patient is in your practice, you've seen them within three years, but you haven't seen them within the last year. And then again, when not enough time is documented. So you may have a list of 100 patients that you're currently running chronic care management on, and at the end of the month when you run your reports, you find that there's 50% of those patients that didn't quite meet that 20-minute mark. You cannot bill those. So I'm going to talk about the successes from our practice, from our experiences with chronic care management, and explain the implementation success and barriers, or as I'd like to call them, learning opportunities that we've experienced with chronic care management. So here at Advanced Medical House Calls, we began chronic care management approximately a year ago. It really fit in line with the way that I wanted to practice. It was a very proactive approach to care. What I learned from my past was that it seemed like most medical care was reactive. Somebody would call in with a problem, we would react to their situation, we'd take care of their problem. I wanted to do things a little bit differently. Back when I first started, I was running a solo practice, and you can imagine the monumental amount of reactive calls that I was managing by myself. So I kind of was looking for a better way to handle this, and I started researching, and I did find the chronic care management program, but it was a little bit too complex and involved back then. But with the lightening of the guidelines and the rules, we were able to implement it at the beginning of last year, and even better this year because of those lightened requirements. So I began myself about a year ago, like I said, and this year I added a registered nurse. I chose a registered nurse for our practice because I felt that that person had the knowledge and the wherewithal for implementing and teaching with the patients the plan of care. The chronic care management that works at our practice, chronic care manager, registered nurse that works in our practice happened to work in skilled nursing. And in skilled nursing, you definitely build your plans of care when you're taking care of that patient, and then you send the 485 off to the doctor. So I knew she'd be really familiar with the terms. Then we decided on what chronic diseases that we were going to implement in our practice. Well, for me, it was kind of a no-brainer. We definitely, being that the mean age of my practice is 88 years old, we started with Alzheimer's disease and cognitive impairment. And then from there, we went to diabetes, congestive heart failure, and hypertension. We're working on a couple of new ones as well, but those are the hard ones that we have implemented in our practice right now. We went to best practice. We designed our guidelines of care around best practice and standards of care. We definitely went by the U.S. prevention guidelines and the WHO guidelines and the healthy heart for our hypertension. And Alzheimer's dementia, we used a lot of the guidelines set forth by the Alzheimer's Association. And it's nice too when you incorporate those, because you can use their educational materials as support materials when you're either mailing or direct portal. We did not sign everyone up at the onset of care because my practice was already 3 years old. But if you've got a practice where if you're lucky enough to just be starting your practice and you haven't even opened your doors yet, my suggestion would be to sign up everybody at the onset of their care, but only bill them as they're appropriate. Your provider that's providing services to the patient or your chronic care management nurse can explain the benefits of chronic care management to lighten that load for you as a provider, telling them the requirements that it is applicable to Part B and what they can expect throughout the program. We also do direct mailings when we initiate a patient into chronic care management. In our practice, we not only have the patient that we take care of, but we also have their family, because most of our patients have guardians or durable medical powers of attorney. So a lot of our education is really with that durable medical power of attorney, as opposed to some of our patients direct. At the onset of care, we have our patients fill out health risk assessments, or we have their caregiver fill out health risk assessments. We identify the needs where we feel that they might need a more proactive approach to care. If they're not following with preventions and guidelines, or things like immunizations, we definitely focus on this as our educational points. Provider reviews and documents, and then initiates that G0506 code, which lets Medicare know that we're initiating that patient into practice. And then the provider then alerts the chronic care management nurse about the patient being inducted into the program. So explaining the benefits to the patient, some of the things that we've found is that, we definitely let them know that by implementing chronic care management with them, telling them the benefits of chronic care management, we definitely have an increased compliance with our patients. So we let them know that it's patient-centered. This all revolves around you, our care is very specific to you. This is not a one-size-fits-all, and we try and treat our patients like we would treat our family members. So we let them know that. When we initiated the chronic care management program as a formal program, we built into our practice to allow for clinical staff time, whereas before we were trying to run it and it was kind of hectic because we were trying to implement it along with everything else that we were doing in our practice. We let them know that we're available for their 24-hour urgent needs. Again, I cannot stress enough, you need to let them know that they're urgent needs, that these are not needs that are maintenance. Realistically, this becomes a benefit to the patient because they're going to have less office visits, because sometimes patients will come in to a practice for reassurance. So if you can kind of educate them and arm them with the information that they need, they may not be coming into your office as much. For those doctors that do rounds and round services, this is definitely a benefit, because if you're educating your patients and you're keeping them healthy and lowering their blood pressures and lowering their hemoglobin A1Cs and helping them be more accountable for their own care, you're going to be doing less hospital rounds and free up your own time, because these patients are going to be accountable and they like the fact that somebody is calling them sometimes on a weekly basis and checking in with them. So you will see less hospital admissions and free up your time. The chronic care management also serves as a triage-like service, because if sometimes on the flip side of the coin, patients will be more acutely ill than what they would like to admit, and they're delaying seeking care. And that nurse can also act as a triage nurse. And it definitely helps because, again, like I said, if a person is coming in and you're following them up for their blood sugars per se, and you're having them keep a blood sugar log, and you ask them to bring that at their next visit, their Part B deductible or copay is going to be much larger than the deductible or the copay of a chronic care management visit. Roughly in our practice, for a straight Medicare patient, it's usually right around $7 for that copay, $7.43 for that copay, as compared to an office visit, which our visits aren't necessarily office, they're in home, but that's roughly right about $25. So again, implementing that, doctor, nurse practitioner, PA creates that plan of care, develops those patient-centered goals, has a problem list that's in the chart running with goals for the chronic diseases, makes the appropriate referrals to community resources such as skilled nursing, those behavioral healths, and any other community resources out there. Somebody might not need skilled nursing, but they may need a geriatric community center to drop mom or dad off for, day sitting services. We've noticed that as we've been implementing the chronic care management program, we're definitely finding a lot of gaps in care that previously we could not identify, and we're closing those gaps. We've reduced our hospital, in 3 of our buildings, we've reduced our hospital admission rates by 72%. Medication management and reconciliation, our providers do that at every visit anyway, but this just gives an extra backup for the patient and patient safety with polypharmacy specialists and everybody else that's out there prescribing for the patients. It's really important that we maintain med reconciliation for them so that they're not getting duplicate medications. And then patient or the caregiver gets a copy of that care plan so that we can all stay on the same page and our goals are all consistent. And this just provides for better care coordination for the patient, not just in our own practice, but we found a lot of specialists who are not implementing chronic care management definitely appreciate that there's one person that's sort of like the house for this patient, because we send these out to our specialists. So what are the responsibilities of your chronic care coordinator? Every month, our chronic care coordinator has currently about 150 patients, I think. So she answers calls and makes calls. She reviews the labs that the providers have already reviewed. She goes over those with the patients and then makes referrals as needed for our provider staff. She coordinates care between team members. She acts as a liaison between our skilled nursing and our providers and kind of summarizes their care as it goes along. And she'll oftentimes go in and read those 485s and make sure the patients are hitting their goals that they had previously when they were on skilled services. Reviews the chart for compliance and health maintenance with the patients, making sure that they're following up on the guidelines and preventative services that they're due for. And if they choose not to do them, asks them why and definitely encourages them to. It's also a great tool for transition of care between hospital and rehab, emergency room visits, and skilled nursing facilities. Oftentimes there's huge gaps in care when a patient is discharged out of a hospital. So what happens from the hospital to when they go to rehab, and from when they go to rehab and then they go home, there's this huge disparity of what happened, and a lot of family members are very confused because nobody's communicating with them. So we sort of act like that filtering house that provides them with that gap in the knowledge that they were missing from transition to transition. Again, we educate our patients and our caregivers. For us, it's very heavy in that caregiver education piece. Our biggest focus this year so far has been the dementia care, really working with our family members on understanding the phases of dementia. And this program for us has gone over great so far. We've had a lot of great feedback. Document your time, and at the end of 30 days, beginning of the next month, we tally up our totals and we submit our billing to the billing department. So what are the benefits of chronic care management to your program? Increased patient satisfaction is probably the biggest. 24-hour access for those non-stationary needs, the non-urgent needs, or I'm sorry, the urgent needs, timely appointments and follow-ups, less frequent appointments. They feel is a huge benefit to them, so they're not having to come in every 2 weeks or every 3 weeks. And a lot of our patients feel really special with the care that we're giving. I'll share a story that I actually just got today. One of the 88-year-old females that we see is a brittle diabetic, and today she called me on my cell phone to tell me that she had very little support prior to coming into our practice, and she said, she really wasn't trying to be too accountable to her blood sugars or her hemoglobin A1Cs, but that she felt that when she had somebody who was calling her weekly, that this really increased her accountability to what she was putting in her mouth with each meal. And she was actually now checking her blood sugars because we had gotten her a glucometer that she could actually see, and then the glucometer spits out a number to her, but verbally. So she couldn't do her sugars before because she couldn't see her glucometer. So she just said that she really felt like she was a person, not just a disease. And to me, that story this morning was huge because that is one of the whole reasons why we implemented our chronic care program. For physicians and for the practice, it's stories like that. It's, health maintenance is being better accomplished. Patients are staying on their schedules for that health maintenance. Again, less rounds in the nursing homes or hospitals because the patients are staying out of them. More free time for the physician because they have tighter control of their patients. And by control, I mean your patients are healthier. The financial benefits for the care that's being done were previously not compensated so well, or if you weren't implementing chronic care as a billing potential, then now you've got the ability to be financially reimbursed. And I will say that the chronic care management nurse that you hire to your practice will pay for herself. Financially, at $43 a month, 50 patients roughly generates between $1,500 and $2,000, and you get 200 patients to your practice, and that's roughly about $6,000 to $8,000 a month additional to your generated revenues. So you can see how over a year that would really add up. And again, it ultimately for our practice, it's all about that better patient care. It's about best practice. It's about what's best for the patient and taking care of their needs. So some of the barriers or learning lessons that we've had to chronic care management for sure is that having enough staff. Originally, when I was running this on my own, I was seeing patients and trying to implement the chronic care management program. It was very ineffective. So having the right amount of staff in your practice and deciding what's appropriate and how many patients a chronic care management nurse can handle. We've decided that number is roughly about 200 with the other duties that our staff has. More paperwork, definitely, because you're definitely keeping track of things differently than you were before, where you might have verbally said to somebody before, hey, I want you to track your blood sugars and bring them to your next visit. Now, instead of just saying those words, you're documenting that out. So it does take a minute. If somebody calls in, you have to pause, leave your chart, go into another chart, and document that. So that therefore leads to disrupting your workflow if you're already involved in something and you've got those things that are constant little interrupters. Staff training, that was a barrier at first because CMS doesn't put too many guidelines out there about what they expect out of this program. So it's kind of been hunt and find, Googling, and finding people who are actually implementing chronic care management programs and reaching out to them to see if they'll collaborate with you. And of course, another barrier is at first when you first hire those people to bring on into your chronic care management program, they're not producing for you at first revenues. So it takes about a good 2 to 6 months before you start to see your overhead burdens lessen. If you don't have a certified EHR, certainly you need to get one. You need to update your EHRs. Some EHRs may or may not have chronic care management built into them, and if they don't, there are supplemental services. We currently have another service outside of our EHR that we use as a supplement to our EHR, and then we scoop all of that information in at the end of the month. You do have to have secure emails with 24-hour access. And then if you don't have the portals for transmitting that information to other providers, you do need to make sure that you pay for those services to get your documents securely over to those other providers. For patients, the barriers that we found in our practice definitely are copay. Our Medicare recipients are already on limited budgets, especially those that are paying to stay in assisted living facilities. So some of them may find that the copays are a little bit troublesome, even at $7. If you do have hardships in your practice, you can put together a hardship letter. I have some great examples if you need them, where if your patient has a hardship, you can have them fill out that paperwork, and as long as you keep that on file, then you are able to help them with their copays. Cognitive impairments, again, like I said, a lot of our patients are cognitively impaired, so a program that's so proactive in education for the patient, we're not only educating our patients, we're educating our families, and our families that are taking care of our patients are very busy, so nailing them down to document that time spent with them often becomes troublesome. So we do rely heavily on our portal and educational materials. We may leave messages and they may call back later, which we try and catch up with them at that point. As far as the patient, sometimes the follow-through can be really hard for them because they are living alone and they don't have the resources out there to help them. So we try to find them community programs or community resources that they can utilize that are at low or no cost. And quite honestly, some of our patients are just really super distrustful of another healthcare program. You know, there are so many programs out there that were supposed to be beneficial to our elderly population, but what they found was that they really weren't helpful to them, and they became very distrustful of the healthcare in general. So we really have to be cautious about how we approach this with them and make sure that we explain it in sort of a loving manner to them, that this is definitely all about them, that this is not just another program. So there are some resources out there other than what I said, basically just kind of Googling or looking on Pinterest or LinkedIn. And other people that you might know that are running the chronic care management program. The American Academy of Family Physicians has a wonderful toolkit. It is for purchase. You do have to pay for it, but it is a lovely walkthrough of the basic items of a chronic care management program. It's not super specific. It leaves a lot of lacks in there. But I think that's only because CMS hasn't really defined down exactly what you need to document and what's needed for that. And then CMS has a chronic care management program there that they run on their website, and they do have some webinars that you can watch and view. They don't really have anything in print at this point that's been super beneficial to my practice, but they do have some guidelines out there. And as I said, other providers who are willing to share. If you can find them and they're willing to share with you, sometimes I think that picking each other's brain is the best collaboration. And then, of course, if you're interested in the fee schedule for that, you can go to Medicare's fee-for-service physician payment schedule and check out the current reimbursements, and those will change in 2018. So if you're thinking about implementing that into your program and trying to figure out whether that's going to be beneficial financially for your practice, you can look there. But I will say from firsthand experience, the financial rewards pale in comparison into what the patient rewards have been, which is improved health care across our continuum and across our board. So if there's any questions, I think, James, if you have any questions for me?
Yes, first of all, excellent material and information. Thank you so much, Laura, for walking us through what you've been able to build. I don't know if we noted this before, but this year you're located in Michigan, correct?
That's correct.
Yep. So what you're doing up there in Michigan is really remarkable, and there's been actually a lot of questions coming through some of my email today, even about, can we get this presentation out? We really want to learn more about this. This is a great topic. So couldn't be better timing. We do have a couple questions that came in, so I'll start with the first. The first question is, what do you do when someone else is doing CCM on your patient?
So if somebody else is billing CCM on your patient, that was one of the things that I guess I forgot to highlight. Only one provider can bill for a patient's chronic care management program. And if the patient is yours and they belong to your practice and you're the primary care provider, you basically tell them kindly step back. The patient belongs to our practice. We're billing chronic care management for that patient. We're responsible for their plan of care. While I appreciate what you've done for them, I will incorporate your ideas and thoughts into our plan of care. But I don't think a specialist sees a patient enough to encompass all of those ideas and thoughts. So I do ask them to stop billing.
Okay, great. The second question is a caregiver applicable to give CCM education?
Absolutely. In our practice alone, James, I think that is probably where our biggest impact is. There's so many patients and so many more to come with Alzheimer's and cognitive impairment, and we really are hitting this super hard because so many people have questions, behaviors and staging and what's happening with my mom or dad, that we've really focused there. And I feel like that you can never provide those caregivers too much education. So we've actually benefited a lot and stopped a lot of those reactive phone calls by educating our caregivers alone.
Perfect. I'm not sure if this question is related to the time factor you were talking about earlier, but the question is, what do you do when someone is over 20 minutes?
Oh, sure. So back on the slide that had the chronic care management services provided, so some patients are definitely more complex than 2 chronic conditions. Like I said, there's a lot of patients in our practice that have 6 or more. So this year, in 2017, some of those nice new changes that CMS initiated were adding more codes. And 2 of the codes that they added were add-on codes to your chronic care management. So if you hit that 20-minute mark and you happen to go over it into 60 minutes, which really, for Medicare terms, is 50, because as long as you hit that halfway mark, you're hitting your time. You can bill additional services, and those additional services, if you're looking at it from the financial perspective alone, can be quite lucrative because you've got your $94 fee on top of your $46 fee. So there's a lot of potential there for revenue generating.
Okay, great. Thank you. It looks like those are the questions we had come in through today. So I'm going to wrap this up. Laura, thank you again for coming on today and presenting this wealth of information. We certainly look forward to future potential talks with you down the road. For anyone that is listening live or on a recorded version, we will get a copy of the presentation out to you soon to your email address for the one that you used to register. And we thank you again for attending today. Look for more from Medix team to announce future webinars for 2018. We look to do this more often as we learn about really important topics in the healthcare and care management industry. Thanks everyone for attending today.